Today, we're going to be talking about the steps of trabeculectomy surgery. By way of introduction, I would like to say that trabeculectomy is a surgical treatment for glaucoma designed to lower intraocular pressure by providing an alternative pathway for aqueous humor drainage. It involves the creation of a fistula connecting the anterior chamber and subconjunctival space through a guarded drainage pathway. The term, the concept of filtering surgery was first introduced by Trabeculectomy in 1882, when he suggested that intraocular pressure could actually be reduced by purposely creating a fistula between the anterior chamber and the subconjunctival tissues. Since then, filtering glaucoma surgeries have gone through centuries of refinement and modifications, from the 19th century when it was the full thickness filtering technique called sclerostomy, till when the Keynes developed and introduced trabeculectomy, and the great thing was the fact that it was through a guarded ostium that limited some complications such as hypertony. In the 21st century, the current goal in trabeculectomy is to create a more posterior bleb that is diffuse and low-lying in nature. The use of anti-metabolites and anti-fibrotic agents is often necessary to help modulate wound healing in order to prevent scar tissue deposition at the level of the conjunctival tenon episcleral interface, which may result in fibrosis and therefore bleb failure. Yesterday, we had an extensive discussion on patient selection, counseling, and informed consent. And we also saw that preoperative care are critical. Some of the things we discussed yesterday included that we cannot overemphasize counseling and signing of informed consent. We also noted that we have to stop some pro-inflammatory anti-glaucoma medications, such as the prostaglandin analogs, ahead of the surgery. Some books say 2 to 3 weeks before surgery. We also have to stop the medications that promote bleeding, because bleeding also predisposes to scarring. So anticoagulants such as warfarin have to be stopped ahead of the surgery. We also noted that when the intraocular pressure is very high, above 40s, 50s, the risk of expulsive choroidal hemorrhage is more. So effort is made to reduce intraocular pressure to a manageable level before the surgery. Sometimes we may have to use IV mannitol in 20% in the dose of 1 to 1.5 milligram body weight to prevent, 30 minutes before surgery, all to reduce blood pressure so that you don't have such a sudden decompression. We're also thinking of how to prevent endophthalmitis. We do proper cleansing, the routine preoperative eyelid scrubs with povidone iodine, as well as the eye drops into the eye. So, but today's discussion, we're going to delve into the surgery itself, starting from anesthesia, choice of surgical site, and the rest of them, down to when we have sutured our conjunctiva and the immediate post-operative care. For most of our adult trabeculectomy patients, we do under local anesthesia, except there is an indication for general anesthesia. But for children, we necessarily have to use general anesthesia many times. But what is important is you want to use plain lidocaine or bupivacaine. You don't want to use epinephrine because it's a vasoconstrictor, You don't want to further compromise the optic nerve head. And in these days, retrobulbar anesthesia is not used. Peribulbar injections can be used with care, but it can also cause significant intraocular pressure elevation. But if you do use peribulbar injection, try not to massage, because massaging puts pressure, increases the pressure on the optic nerve. For subtenons, injections, most of the time what we use. Some people use subconjunctival injection or even topical, and these are safer. You can use your Hyalase as a spreading factor. Concerning the choice of surgical site, superior site is preferable because the bleb is covered by the upper eyelid. Moreover, you want to use more of the supranasal space for a fresh trabeculectomy. If you're doing repeat trabeculectomy, you necessarily have to find an appropriate site. You know, you want to use the supranasal site. You want to spare more space for repeat surgeries, which may be repeat trabeculectomy. And most of the time when you have to now do a cataract surgery, you go temporal. Concerning bridle suture, if you don't have the skill for corneal traction, you can still go ahead and use your superior rectus, but corneal traction is preferred because one, the exposure site is better, exposure of the sclera is better, and you avert the hematoma that can occur when you do superior rectus bridle suture. You can use the 7/0 black silk or Vicryl, but endeavor to put some barrier, you know, in the inferior cornea so that the suture does not abrade the cornea. You can see the photo of a corneal, an attempt to put a corneal bridle traction suture. The next step is the conjunctival peritomy. One very important thing about conjunctiva is that it is the seat of your bleb. So you have to be very gentle with the conjunctiva. You want to use a non-traumatic toothed forceps, such as the P.S. Hoskins or the Smooth Bishop Hammonds, or you can use your suture tying forceps, the non-tooth, or you can use your plain forceps, something that will not tear the conjunctiva and give you a buttonhole. So the flap can be limber-based or funnels-based. Most of the time we do funnels-based, especially nowadays when the goal is to create a more posterior bleb. This problem of posterior restricting scar when you do a limber flap. So funnels-based flap is the gold standard, and it gives you the advantage of larger scleral exposure, control surgery. You can put your you can do a better treatment of your sclera with your anti-metabolites. The next step is your hemostasis. The cautery, the small tip cautery, the pencil cautery is better if that is what you have. But you can use what you have. What is important is not to over-treat your surgical space, not to over-treat your sclera. You don't scar you want to do very good hemostasis without charring. Because of tissue contraction, you use a low energy level of your cautery to achieve your hemostasis. You also avoid large vessels such as the anterior ciliary arteries near the insertion of the rectus muscles. You should avoid that, because any bleeding that occurs, you also have to wash copiously, because you don't want bleeding in your site, because that also encourages scarring. The next step is your antimetabolites or antifibrotic agent. Many times here in this country, we use either the mitomycin C or the 5-fluorouracil. It's important to choose a mop that will not give you pieces. The usual cotton board, the methylcellulose sponges, many times cause fragments that may actually be retained in your surgical space. So you prefer the Merocell, the polyvinyl alcohol sponges. And you can see in the place here where I have shown a picture of the Merocell, you can cut small pieces that you can soak with your mitomycin C, usually 0.2 milligram per mil to 0.4 milligram per mil, which you place for 2 to 5 minutes. And your choice depends on the risk factors of your individual patient. So you push the pieces in different directions after you have created your flap. And if you look at this picture on the left side, you will see an attempt to put the soaked sponge under the conjunctiva. I noticed that this surgeon did not cover the cornea. I would usually use some wet mop to cover the cornea because I don't want the soaked sponge to touch the cornea or the edge of the conjunctiva flap. You can see in the other picture, when you have put in the swabs, the pieces of the sponges, you leave for 2 to 5 minutes, depending on the risk factors, like I said earlier. The next stage is to create your scleral flap. The scleral flap may be triangular, rectangular, trapezoid, or even a square. If it is a triangle, the base is resting at the limbus. The dimensions, circumferentially can be between 4 to 5 millimeters, and then radially, it can be 3 to 3.5 millimeters, and recently, even as much as 5 millimeters, because you want a posterior flow. You want a posterior bleb. But the exact size and shape are not as important as the relationship between what the flap you have made and the sclerostomy that will follow after that. You can see in this photo the triangular flap, and it's the section of a triangular flap and a rectangular flap. In the Murphy technique, it is advised that you complete your flap so that you can get to put your Merocell pieces on top, under the flap and on top of the flap, so that you will achieve more treatment of your flap on your surgical space, so that you'll have a better and longer lasting bleb. The dissection, after you have made your, you have this, constructed, you've done your incisions, you pick up one point of, in an attempt to raise a flap. You can use a toothed, but a non-traumatic toothed forceps. You can even use your colibri. I use colibri to pick up a side of it, and use your crescent blade to create a plane. You create a plane and then dissect towards the limbus. This dissection is carried on till you cross the blue line, where the white sclera merges into the gray zone. The dissection is carried further on until you've gotten up to 1 millimeter of clear cornea. Then the next thing, and then depending on how proficient you are with cataract surgery, if you're very comfortable with making your regular SICS tunnel, you can actually do your tunnel as if you were doing cataract surgery, get to your clear cornea, and then cut the sides. Voila, you've made a flap. So if you're proficient in cataract surgery, it makes your trabeculectomy easy. The Murphy technique encourages the surgeon not to dissect straight up to the limbus on the sides, so that you will achieve a more posterior bleb. The next stage is to now do your side port, your controlled paracentesis. The advantage of doing this is that if it is an advanced glaucoma, you can actually get to put visco. You can put visco because you don't want the AC collapsing. It's not that you must, but if you're very worried about how advanced this patient's glaucoma is, you can actually help the patient prevent the wipeout syndrome by making sure that your anterior chamber is always formed, is either by your replacing your balanced salt solution or even by putting visco. So you can actually also use it always to reform your AC, to put your visco, Ringer's lactate or whatever, and make sure that your patient is safe, because it is this collapsing and reformation of the AC, that puts the patient at risk of the wipeout syndrome. The next step is the sclerostomy. Having created your scleral flap, you can now mark out the place where you want to put your inner sclerostomy. 1.5 to 2 millimeters by 3 millimeters at the base of your hinge. It's better for you to be nearer the cornea than to get into the choroid. So you make your AC entry with your keratome. And again, you don't withdraw, whether you're doing the paracentesis or you're doing your keratome, you don't withdraw forcefully because you don't want a squat of aqueous coming. You want, slow decompression so that the patient will not be put at risk. So after entering with the keratome, you withdraw slowly. Then you can use a fine blade to cut and then use your Vanna scissors to create your ostium, or you use your Kelly's Decimet punch. I use the punch, and makes it easy. What is important is that you make an ostium that is large enough to avoid being occluded by the iris. By the iris, yes. But you also have to make sure that your flap overlaps the ostium you have made. At least you leave at least 0.5 millimeter of sclera on either side, and all of that can come under your flap very well so that you don't have part of your sclerostomy, outside your flap. The next stage is to do your peripheral iridectomy. Of course, the aim of the peripheral iridectomy is to prevent iris incarceration into the sclerostomy. The iridectomy base should be wider than your inner sclerostomy opening, okay? And when you are pulling your iris to do your PI, you will not be forceful. You pick it up with a single-toothed fine forceps like the LIMS or Pierce Hoskins. And when you are cutting, you keep your hand horizontal so that by the time you have made your cut, you have a triangular, nice looking PI, which you can actually see through your, peripheral cornea. Avoid forcefully pulling the iris so that you don't end up having an iridodialysis or, damage to the lens. Having done this, the next thing to do is your suturing. You want to, first of all, suture your scleral flap. You choose sutures that will not cause excessive inflammation. That's why we use the 9O nylon for the, corneoscleral suturing. Okay, and the needle is a fine cotton needle. And for the conjunctiva, we use the 8O vicryl suture. When you're suturing your scleral flap, the aim is not to close too tightly and not also to make it loose. If you close too tightly, you occlude the flow. If you make it loose, you end up having overfiltration. The ideal tension on the scleral suture is that will allow slow egress of aqueous at the edges of your scleral flap while maintaining a deep enough AC and intra-op. If it is a triangular flap that I have made, I would usually put one fixed apical suture and two side sutures. Some people just do the apical suture and they're comfortable. It depends on how your AC is and how you ballot your eye, your eyeball, the cornea and the AC. But the good reason for putting the releasable sutures is you don't want hypotony and you want to be under control. You want to be in control. You want to release your sutures, at your own terms as you monitor patient's pressure. If it is a rectangular flap, the ideal rectangular flap by the Murphy's technique that you have made posteriorly up to 5 millimeters, and you have made sure that it did not reach the limbus, it is advised that your side sutures will be fixed sutures, and then the rest of your sutures are towards the apex of at the edges of your wound, the posterior edges will be releasable sutures so that you can be in control. Then comes the conjunctival closure, which you want to make watertight using your non-tooth. I said earlier that you can actually just use your suture tire. You don't want to use any traumatic forceps that will create a buttonhole for you. Tissue apposition is the goal. Tight sutures will chiswire through your tissue, creating a leaky, inflamed wound post-operatively. So having done that, you've actually finished your trap. And what you're interested post-op is to use enough steroids, you use cycloplegics, you evaluate your visual acuity, the status of your anterior chamber, look out for complications such as flat, shallow AC, and as your follow-up period, you're looking for signs of early bleb. Those things will be discussed by another speaker. Thank you very much. But before I end, I want to show this video that was very helpful to me. This video, some of you have it. It was shared by one of our international guests. It was either Leon Hedden or Daniel LaRoche. One of them shared this video that makes any SICS surgeon able to do trap as if it's actually not a new skill. So I'll share it with us. It's just about 5 minutes. I'll share it with us. We can watch it. Okay. At least you can start with this and then learn how to make your triangular flap, your greater rectangular flap. But if you can actually do cataract SICS after watching this video, I'm sure you will have the confidence to do your trap. because in this video, you can see that you can actually do your flap, your normal tunnel, and cut the sides. And you've made a scleral flap, and then you learn the other procedures. One thing to note as you're watching this video is that the corneal traction suture is not lying on the bare cornea. You can see that because it can actually traumatize the cornea. You have to put a barrier, you know, behind it in the inferior cornea so that it will not tear through the cornea, okay? And then as you're watching this video, you will notice some of the steps I had described. Phonics-based conjunctival flap, you know, made large enough to contain the MMC-soaked, you know, metacell pieces. You can see that. Make sure you do a sponge count. If you have put 3 pieces, make sure that what you get to remove are complete. Because when these things are soaked, it can look like tissue, and you can actually end up forgetting, you know, a piece of something inside. So make sure after that you irrigate very copiously with balanced salt solution. After that, if you can see that this surgeon is using the crescent blade to create a normal incision for tunnel, I would go a little more posterior than what he has done, you know, at least 3 millimeters, you know, so it comes a little more posterior than your regular cataract tunnel. But what is here is that he has made his tunnel up to the clear cornea, and he just cuts the side, you know, and his scleral flap has been made. Then he now does the side port. And then he's just using the side port plate. He makes the AC entry and then uses the Kelly sponge to do the sclerostomy. The next stage is to do, you can see how he's holding the scissors to cut, to do the PI. After that, the next thing is to suture the sclera. He has done a rectangular flap. In this case, he's just putting 2 sutures on the 2 edges, the 2 posterior edges of the scleral flap. You can see the side port is helping him to keep the AC formed. You know, you don't want, you know, a shallow AC anytime in your surgery, because that puts the patient at risk. The next stage is to suture the conjunctival flap. See, it's quite a tight, a watertight suture. And that's it. Thank you very much.
Thank you very much, Prof.
Go on, Dr. Afyon, we can hear you.
Okay, all right. Good afternoon, teachers, senior colleagues. Thank you for a great and wonderful presentation, Prof. I think we just take on the second speaker, Dr. Sadiq, and thereafter we have questions because some questions have already come on board already. So thank you. So we'll have Dr. Sadiq taking on the next lecture. Then we can have questions. Please do write down your questions. Thank you. We have a great panelists on board today. So you're welcome, Professor Bola Adekoya and Professor Madi Abdul. Thank you very much for coming to give us great pills and on how to handle trabeculectomy. So we have Dr. Sadiq.
Is my slide
Dr.
showing?
Sadiq, please go ahead.
Am I audible?
Yes.
Yes.
Good afternoon.
We can hear you.
Good afternoon, senior colleagues, professors, teachers, friends, and everyone. I'm actually here to talk about trabeculectomy, falls, and pitfalls. And I'm Abdullahi Sadiq. I am a glaucoma specialist and consultant ophthalmologist at National Eye Center. Now, I actually, for the first yesterday and today, all what I want to say has been said, just to share my experience, basically what I have learned over the years. And so I'm going to describe them according to this, but it doesn't really have to follow sequentially like I mentioned them. But what I know is that from my personal experience, when you are planning trabeculectomy, the choice of patient is very important. In my own experience, GOAG and patients, primary open-angle glaucoma patients that are less than 50 years are good candidates for primary for trabeculectomy. You can do trabeculectomy in patients older than 50 years, but you should be ready to tackle their cataract because most of them, they have some form of lenticular opacifications. And therefore, trabeculectomy is the cataract after trabec is the most common cause of most common cause of poor vision after the procedure. So you need to be ready to manage the cataract after that. But less than 40, you are good to go. And then if you have a case of PAC, you also need to think twice. If you can do lens combined procedure, it's better. If you can remove the lens or combine surgery, it's better. But if you are going for trabeculectomy in PACG patients, you also need to know that PACG are not a very good candidate for trabeculectomy, according to my own experience, and also most of what's reported in the literature. And then another important thing that we need to do, which has already been said, is that manage patient expectations. Generally, I tell my patient the benefit of surgery is in the long term. It's not that you do surgery tomorrow, it's long term. We want to control your pressure over time so that your vision will not get disappeared. And then it's also good to identify risk factors for failure before you start the surgery. Stratify your patients. Like, okay, this is a young patient who has used anti-glaucoma medications for so long time. Or this is a patient who had pseudopecia. And then in my personal experience, a patient that comes from far. You are in Kaduna, patient is coming from Maiduguri, or patient is coming from Taraba, or patient is coming from the east or southwest. Now follow-up become a problem. So when you get all these things before the surgery, it will help you to counsel the patients and to plan your surgery ahead. And another important thing that we need to talk is about the need for frequent visits. It's also good to identify risk factors for complications. So there's typo here. To identify risk factors for complications. If the patient is a high myo, patient with primary angle closure glaucoma. So it's good to consider axial length. Sometimes I ask for axial length to see if I see a patient, I may not be able to do refraction or something, but sometimes it's good to ask for axial length. If you see axial length of less than 21, you know, are in for problems. And then if you see axial length of more than 25, 24, 25, 26, those are high myopes. So you should also be, these are the patients that can have hypotony on the other side. That is the myope. And then these are the patients that can have malignant glaucoma. We have had patients, a couple of patients that had malignant glaucoma. And also macular splitting. What it means is that you need to check the visual field. I have a picture of showing macular splitting that one of my patients showed, that we did on one of our patients. And then you also plan post-operative care before the surgery. Now, this is a young man.
Who are you complaining about?
This is a young patient who has been on anti-glaucoma medication for so long. Okay, then I will have to start thinking of high-FFU injections, frequent hospital visits, planning a large PLAF, large osteum, you know. So you must have this even before you start the surgery. And you also plan your surgical approach preoperatively. This is a patient with a high myopia, then I need to be sure that my sutures are tight. You know, it's a patient that has it's a high myo. So these are the things. Before the surgery, you have already planned what to do, not to just jump into the surgery. And that's what I mean by macular splitting. This is CBF 10-2 of a patient with very advanced glaucoma. You can see they have only tunnel vision. So the macular splitting is actually when you have, you can see this, the central 3 points at the fixation. When there is any defects in either of the hemiphiles, then there's macular split. And these are the patients that are at risk of wipe-out syndrome. So when you have patients like this, okay, this patient has advances, is tunnel vision with macular splitting. He could have wipe-out. So what are the precautions that I need to take? So these are the patients that if they have high pressure, you need to give them mannitol. You need to give them IV mannitol, especially if the pressure is more than 25. You also need to use small volume anesthesia, usually 2 mL if you can. And then sometimes Softenin is a good option. And then also these are the patients they would like to put, you don't want them to have hypotony after the surgery. You also don't want them to have high pressure. So you need to use tights to use releasable suture and control the pressure. So all these things are some of the decisions that you have made even before you take the patients to the theater. This is one of our videos, which I have already, she has already explained virtually everything, just a little points to. Now this is how I do my trabeculectomy. I start with 5-AVU injection. You can see I'm giving subconch 5-AVU. about 7 mm from the limbus. It's not at the limbus, it's far away, because I don't want the MMC to come here, because I want wound healing around this side. So the MMC is given away from the limbus. And then we make sure that we spread the MMC so that we don't have a localized, so you can see MMC is spread across so that we don't have a localized cystic bleb. And then she has already explained all the steps, but just a little bit of this thing now. And if you can see this video, you can see at this point, let me stop here. We didn't start the initial incision at the limbus, a little bit like 2 mm behind the limbus. And the idea here is that that is the point of insertion of the tenon. So if you make incision here, you're going right into the subconjunctival, soft tenon space. So you can see, so we're all, I'm only trying to, we're all trying to get to the soft tenon space. So once you're in the soft tenon space, then you can now undermine. And then another point here is that you can see a little bit of conjunctiva is left here. And then, so this is to ensure that it's watertight closure of it will help in the watertight closure of the conjunctiva and also prevent the incidence of wound leak after the surgery. And then the next thing is you need to undermine. Like you can see, she has shown all that in the videos, in the video she shared. So I'm not going to talk much about that. So you can see the undermine is on the other side because you won't have a diffuse blade. You don't want to have a localized blade. So you need to go, and you can see this is tenons, yeah. So everything is in the subtenon space. So in the video that was shown earlier, it was rectangular flap, but this one is actually a triangular flap. I am using a crescent blade. But you can see here too, we did not start at the limbus. The incision here did not reach exactly to the limbus. It stopped short of the limbus, like in. So another important point I want to stress is that whether you are using rectangular flap or you are using triangular flap, you have one important anatomical landmark that you'll be looking at immediately you start dissecting and approaching the limbus, and that is the blue zone. You have to cross the blue zone and enter a little bit into the cornea. And this is very important because, so you can see this is the blue zone. Now you can, this is the blue zone. So we're already at the blue zone. And this is very important because if you enter here, you get into the choroid. Then if you enter here, you are safe. You are now going to catch the iris, but any entry you made at this point, you are going to catch the choroid. So the anatomical landmark there is the blue zone. And once you do that, to be safer, you can make a little bit of tunneling into the clear cornea so that you have a more space to do integrate internal osteum. And that's what this thing is doing. So we're having a bleeder there. But at this stage, you see, when you have a bleeding, when you have already raised flap, it's difficult to use, it's not advisable to use cautery because it will shorten the flap. Once you apply the suture, the tissue will respond and it becomes shortened. So you'll have a shortened flap and you have difficulty closing it. So now you can see this, the osteum is created at the blue zone. Now this is, okay, let me see. So this is to identify the sites of the trabeculectomy, is to properly visualize the site of the future osteum. And so this is, I know I passed this stage now, this stage. Now, before the osteum is created, we apply this apical suture here. Now, the aim of this suture is this is before the trabeculectomy was done and before the osteum was created. So the whole idea here is to reduce period of hypotony, so that immediately you do your trabeculectomy, you can easily suture. So after this suture was placed, the next thing then, the osteum was now created. So that's another important tip, putting the suture before the osteum. It helps you in early and quick closure of the flaps, reduce the period of hypotony. And more especially if you are dealing with a patient that had advanced disease that you are worried of, and then you can see side ports here is created. Paracentesis is created before so all these things are to, especially if you're having a patient that has advanced disease and you're worried of wipe out syndrome. So these are the kind of patient that you don't want a prolonged period of hypotony. So I'm using the crescent to make an incision right at the blue zone. So that is scleral punch, yeah, going and going the other direction. And once you have a good size osteum, you will see iris coming out saying hello. So another thing that you can see that this osteum is almost equidistant from this to this, from here to this. So the osteum is actually at the center, and then if you can see, the osteum is almost at the apex of the triangular flap. So it's always good to be conscious of these small things. It helps you in proper closure of the osteum and in even distributions of the aqueous egress. This is actually Rex's process. So sometimes you can have problem here. If the osteum is not big enough, you may have problem pulling the iris out of it. So sometimes what one needs to do is to a little bit enlarge the osteum so that effortlessly you can drag the iris without causing much damage to the tissue. And then you can see here that, let me go back a little bit. I just want to show where the cut on the PI for the PI was made. Let me see. That's still showing. So, but so I just want to show that when you are cutting the iris after you pull it out of the osteum, the iris is cut at the base so that you can have a rectangular shape PI. So this thing could happen. This could lead to wearing of the iris. You can see here, I've been trying to catch the iris, it's not catching. Two things could happen. It's either the instrument is not good, or the osteum is too small for the iris to come out of it. It's really a very old video, so I got it from my archive. Exactly. So this so the scissors is at the base, so you can actually make the scissors flat on the surface of the eye as you cut as the iris is being exactly. So now that's what is done, and then so immediately we did that. I like to put air to reform the AC before closing the scleral, the apical suture. And then other procedures like as she explained. So we put a releasable suture here. And then I think the patient has releasable suture on. And then the conjunctiva was actually closed with a Vicryl. And then you can see surgery finished. You can see the conjunctiva is well upwards. These are some of the tips I would like to share. But post-operatively, we want to see diffuse blade. We want to see good IOP control without any form of complications. These are my post-operative regimens. We give steroids to hourly for 10 days, then QDS. Everybody has his own regimens, but this is what I develop over time for myself. And then so I give IVVU at 1 week, at 1 month, and then at 3 months, sometimes PRN in between. And then early needling. Once you see signs of failure, it's good to do needling within 3 to 6 months. And now, so you can see here, this is diffuse blade. You can see there's some mix of vascular and avascular area. We don't want to be completely avascular. You don't want it to be completely vascular. You need to have a good mixture of the two. So post-operatively systematic evaluation. To improve your outcome, you need to have systematic evaluation of the patients after the surgery. You want to look at the vision, whether the vision has reduced or remained the same, or in some cases improved. But the most important thing is you need to know how to assess flip.
Dr. Sadiq, we can't see your slides. Is the video that is still playing?
Oh, is the video still playing? Oh.
Yes.
Okay, let me stop sharing Arisha again. So what about now, ma'am?
Yes, If you can go back maybe two slides.
Exactly. So you can see this. So this is so post-operatively, this is what we want to see. We want to see diffuse bleb with good pressure and then no complications. And this is my post-operative regimen: steroid 2 hourly times 10 days, and then QDS 5 APU at 1 week, at 3 months, at 1 month, and PRN. And then if there is need for needling, it should be done within 3 to 6 months. All this help in the survival of the bleb. And now this is, you can see this blade, to say a good mixture of the vascular and avascular. We don't want it to be completely avascular, and we don't want it to be vascularized. And usually the vascularization is relative to the adjacent conjunctiva. As you can see here, versus here, this is avascular compared to this side. So, but this is what we do after trabeculectomy. We want to check the vision, we want to check the bleb, the AC, and the IOP. But let me talk a little bit about the postoperative bleb assessment. It's very important. And in my practice, the vascularity, CDAL, and IOP are the most important one that I look at. Now you can see the vascularity is, now because this bleb is highly vascular, it's more vascularized than the adjacent conjunctiva. But you can see this is the bleb of the initial patient that I demonstrated. Now in this patient, you need to do something because you can see there are a lot of corkscrew vessels here. So this is just a matter of time. This bleb is going to fail. Now, so another important thing that you always need not to forget is CDAL test. Now, see, this is one of the patients after the CDALs. Sometimes patient may have CDAL positive with a normal anterior chamber, they have normal vision, nothing. The only complication, the only complaint the patient will tell you is that sometimes the eye is watering. So one of the tips that I want to share is that when you see pressure of 7, 8, before you celebrate, do CDAL. Sometimes that low pressure may be due to a slow leaking bleb. But the good thing is that some of them can be managed with BCL. This is the patient who had bleb leak, and you can see with the BCL and the condition was managed. So it's good to know how to assess bleb. This is one classification that I like. There are other classifications like Indiana bleb classification, Morfield, but this one is quite, people can read about it. And now, if you want to improve your trabeculectomy, there are certain postoperative interventions that you need to master. You need to know when to increase steroids. So there's a typo there. You also need to know when to do digital ocular massage, when to remove reservoir suture, 5-APU injection, bleb needling, BCL, cataract surgery. So that's why glaucoma is on intervention clinic. So you must have some of these things. So now let's take about this, for example. This is a case that has increased vascularization with corkscrew vessels everywhere. Now in this case, I would like to increase my steroid. If the patient is using steroid 2 hourly after 10 days, I would like to increase the steroid to prolong the duration of the 2 hourly steroids, and then give the patient 5-APU injections, and then prepare the patient for bleb needling. So you need to know when to do this kind of small intervention. It helps in the survival of the bleb. Remember in trabeculectomy, you create a wound, but you don't want the wound to heal. But the natural process is that the wound is going to heal. Once wound is created in the body, it will heal, but you don't want it to heal. So you have to actively stop the wound from healing. And this is what you need to do post-operatively, is trying to take telltale signs of failing bleb, which is actually signs of healing. And this is one of those things that you need to look at: vascularity, pressure. Now, if you have this case, even if the pressure is 10, even if the pressure of this patient is 10, you need to do those things, because just a matter of time, it will heal and the pressure will start going higher. So another thing, you need to identify failing bleb. Now, this is one of our patients that we operated sometime in 2021. You can see we have some, the patient has some little bit of good bleb here. But look at what it ended up with. You can see this large vessel is still appearing here. And if you look at it, you can see it from here. So this is a sign that you need to pick this there. The bleb is really failing. Then you need to intervene. You need to give 5-FU, increase steroid, give more frequent hospital visits. And this trabeculectomy has already failed in this man. You can see really.
Hello, Dr. Sadiq.
This man.
Thank you very much. We're just trying to keep you to trabeculectomy for now. We don't want you to delve too much into the post-op. We would like to keep it for tomorrow.
Actually, they said the lecture say pass little tip that will help you in survival of the
Left.
blade. And now in survival of, and these are some of those things that you need to identify them early and do something about them, because
Yes.
Because you may be having, you may be okay with pressure of 10. Meanwhile, you did not see that the blade is actually.
So
These are
that's
some
what,
of,
let's just keep it within the trabeculectomy, just like summarize.
okay, fine. So in summary,
What is going to be discussed post up tomorrow. So we don't just give us that little tip for trabec now. Let's leave a lot of the post-ups.
in summary, trabeculectomy remains the gold standard for glaucoma filtration surgery. And mastering the technique, it improved the success of the procedure. Thank you very much.
Thank you, Dr. Sadiq, for such a wonderful presentation. I know we tried to bring you back. You're almost going. You have so much to tell us. So thank you so much. We have some questions already on the chat group. So I'll just read out a few that we'll deal with before we call for the panelists and more questions. So thank you very much. So we have you, Dr. Sadiq. He says it's cycloplegic a must. Am I being heard?
Yes, you are.
Hello.
Keep on. We can hear you very well,
Okay.
Prof. Yeah.
Okay, so it's cycloplegic a must for all trap cases. That's a question. The other one is for Dr. Sadiq. Explain more on suture and high myop. The other one is explain more macular splitting and how to identify it in CVF. Then you said, somebody wrote that you said cataract surgery after trabeculectomy is a common cause of poor vision. Please explain. So I would like you to take on this one before we call on Professor Bonaya to take on some other questions, please. Dr. Sadiq, are you with us? Hello?
Okay, can you hear me? Can you hear me?
I can hear you now.
Yes,
so
sir.
please, did you get the question?
Yes, actually, I mean, cataract is the commonest cause of poor vision.
Okay, so, okay.
Yeah, it's not cataract surgery.
It's not cataract surgery. Cataract itself, after trabeculectomy, is the common cause of poor vision. So I believe that has been handled. So macular splitting, somebody is asking, how do you identify it on your visual?
This is the.
Could you put it on slideshow?
Yeah, this is it now. This is CBF 10-2. Now, if you look at the inner pore points, 1, 2, 3, 4, this one now, the inner pore points. If you have any of this dark spot anywhere, and that is macular splitting. Now you can see this in a study that compare horizontal to like this versus vertical. When it is horizontal, like this one now, this pore point, the two are horizontal.
Okay.
Then what about if they are all but what about if they are vertical? Two are vertical, like not horizontal. So people are arguing which one is more at risk of wipeout. And then another one is that each one represents 25% chances of wipeout syndrome. Like this one now, that is two are involved, means there's 50% chance of wipeouts. If it is 75, if it is 3, it's 75. If it is 4, it means 100%. But to be honest, we have done many with 3 and even 4, and yet we do not have wipeout. But that is not to say wipeout is not real. It can happen.
Okay. Thank you very much. And somebody said, but before you go on, I would just like to make a correction. It's Professor Olawoye, our chairman. I'm sorry, ma, for calling another person to be on the panel today. You are the one with Dr. Abdul on the panel today. Please, sorry for that mix-up. So, Dr. Sadiq, please continue. A question on explain more on suture and high myop. I think you said something. And then it's cycloplegic.
Now, the issue is
for all trap cases.
the issue. To be honest, I will advise everybody to use cycloplegic after trabeculectomy only. If trabeculectomy is combined with cataract surgery, cycloplegic is not a must. But if it's a single trap, then it's really recommended that patient should be on it. It deepens the AC. And then but the issue of myopes, what I said is that what I say about myop is that myop are more likely to develop hypotony. Hyperop are more likely to develop malignant glaucoma. So if you have a high myop that's going for trabeculectomy, you don't aim for very much filtrations on the table. So you want to have a tight sutures to be sure that you are not aiming for any much filtrations on table. And even in the immediate postoperative period. So put your tight releasable sutures and then aim for gradual functioning of the trabeculectomy. You don't aim for excessive filtration on table. So that's what I mean by putting those sutures. Then after 1 week, you can remove one. After another week, you can remove another one. Now, in the case of the hyperop, these are the patients that have short axial length, and are the patients that have PACG, and the patient at risk of malignant glaucoma. So these ones too, we don't want to get a very large osteum. And these are the patients that you need to put tight scleral sutures. Again, too, you also need to follow them up with acetazolamide tablets. So you try as much as possible to also dry the vitreous and reduce posterior pressure. So these are the things that you need to really take into cognizance.
Thank you very much, Dr. Sadiq. Please, would like the panelists to please weigh in on this discussion. There are people with great experience in trabeculectomy, Professor Olawe and Dr. Abdul. Please, the floor is open for you to share your wealth of knowledge and experience on trabeculectomy with us before we take on more questions that you have on the floor. Thank you so much, Ma and Sir.
Thank you so much, Prof. And please let me use this opportunity to thank the speakers. I mean, this has been very fantastic, and the presentations have been excellent, excellent. Thank you very much, Dr. Sadiq, and thank you very much, Professor Bunaya. You made it simple and easy to follow. I just want to add a few things to what has been said so far in terms of, the pearls and the things that one should take note of as one does the surgery. I must say that there are 1,001 ways to do trabeculectomy. This particular surgery is so diverse, and people have, different ways of doing things. However, there are just basic principles which has been very well highlighted by Professor Bunaya and Dr. Sadiq. Just to mention also that the superior bridal suture should be avoided. Corneal traction is better. The reason is that, the superior bridal suture can cause ptosis, can cause subconjunctival hematoma. So, most glaucoma surgeons will do the corneal traction suture. Do not overdo your cautery. If you do that, you can have scleral shrinkage. So you should look out for that. Just, target those vessels that are bleeding and cauterize them as much as possible. Don't just keep cauterizing everywhere on your scleral bed. Just to also note that one should try as much as possible to avoid perforating vessels. You see them as black spots on your sclera. Sometimes you are not able to avoid them, but as much as possible, if you can, they should be avoided. It is good to have a moderately large flap so that you can have a moderately, large sclerostomy. Now, when I say large for sclerostomy, I mean it should be moderate, but you want it right under your flap, just like Professor Bunaya said. But it's good to have a good sclerostomy in our population especially, and then control the amount of aqueous that comes out of the eye using your sutures. So you can make them tighter. If you have a large sclerostomy, they are more unlikely to close up over time. Like I said yesterday, pilocapping is good. Always try as much as possible to put pilocapping before you start your surgery. It makes your iris taut and it makes it easier to do your iridectomy, especially in patients with floppy iris and all of that. So you don't want to do your sclerostomy and then you have iris just popping out even when the sclerostomy is yet to be complete. It is so important to think of the trapdoor mechanism. Sometimes your sclerostomy is not complete. It is not through and through. You have a hinge somewhere that has not been removed. And so, how do you know this has happened? Well, post-operatively, the intraocular pressure will be high. When you massage, the intraocular pressure will come down because the trapdoor will open. And then it will settle down again, close up, and the pressure will go up right after your surgery. So it is so important that you avoid a trapdoor mechanism around the area of your osteoma while performing your sclerostomy. So how do you identify this on the table? I mean, it's one thing to identify post-operatively. The paracentesis is so important. After your sclerostomy, you should be able to see your iris easily. And then, so once you sort of find out that you're not really seeing your iris or you're not sure, you're seeing it, but you're not sure, use your paracentesis, pass in some BSS and see how it comes out. You can actually identify it right there on the table. Ensure that you do a complete full and full sclerostomy. Ensure that you do, you have your iridectomy and you cut it at the base just as has been said. The other thing is make your releasable sutures firm, not too tight, not too loose. I think that has been said. And then there's a lot of controversy about when to put your NMC. So some people say, oh, you put it on the scleral bed. Other people say you raise your flap before you put the NMC. Well, most schools of thought will say, raise your flap. Don't get into the eye. Don't get into clear cornea. But put your NMC before you get into clear cornea, before you get into even the blue zone. Just raise your flap and put in your NMC under the flap so that you can avoid episcleral fibrosis or fibrosis in the subscleral space, especially again in our own population. We have used diflucor, which is diflupregnate, over years, and we have found it very, very useful. You just find those blebs white, almost white, not completely white because we still need some vessels there. But we found out that we never had those corkscrew things anymore and all of that. Diflupregnate is Pred 40 and it works very well. I just want to say that many people avoid trabeculectomy in advanced cases, and these are the ones we see in our clinics. But we have done quite a number of trabeculectomies, and I can tell you that wipeout syndrome is very, very rare. Yes, the risk factors are there, and I like what Dr. Sadiq has said, that they have also done quite a lot of those kind of, very advanced cases, and they haven't even seen wipeouts. Doesn't mean it's not there. We need to be careful. We need to take precautions not to have them, but, they are quite rare. Releasable sutures are very important in advanced cases, like I said. And then the other thing is, once you finish your surgery, please use your paracentesis again. Make sure you push in some BSS. Be sure your bleb is forming on the table. Be sure there is no leakage. Be sure that your sutures are tight enough. And once you see your bleb, fill out. And you look, there is no leakage. Everything looks good. Sutures are tight and well buried. Then you can say you have concluded your surgery. It is also important that you don't fidget around the sclerostomy when you're trying to take out your iris. Once you pick the iris, you cut it. Again, once you cut the iris, please don't go back to say, oh, the iridectomy is too small. Let me try and widen it, especially if the patient is phakic. You may just traumatize the lens, which is just right below your iridectomy. Now, somebody was asking, why cycloplegics? Cycloplegics is important in all cases of trabeculectomy, except those ones that have had cataract surgery before your trabeculectomy. Those ones may not need cycloplegics. But all patients should ideally have cycloplegics. It helps your anterior chamber to form very well, to be deep. It pushes away the lens iris diaphragm, And it helps the patient, to also be a bit more comfortable, especially if there has been a lot of inflammation around your cervix and all of that. Now, what's cycloplegia? Some people will put 1 drop of atropine, and that will take them for about 2 weeks, 10 to 14 days, as we know. So 1 drop of atropine on the table, some people will do that. Other people will want to continue the atropine for a long time, but cycloplegics are so much more important in patients with angle closure glaucoma. Of course, in everybody, but much more in patients with angle closure glaucoma. Now, removal of the releasable, you may not need to remove the releasable sutures, especially if your intraocular pressure is fine, the blood is good, everything looks well, and if you've tucked in your releasable sutures, you may not need to remove it. So these are some of the few highlights that I just wanted to bring out. Trabeculectomy, I like what Dr. Sadiq does by giving the 5FU, subconjunctivally. I think that may also help. But if one gets access or has access to diflupregnate, I think it goes a long way to ensure that your bleb is perfect. Since we started using this, it's been so rare before we use subconjunctival 5FU, let me put it that way. I can almost say in a very long time, more than a year, not more than several, in fact, more than maybe a year to 2, I've not used 5FU in any of the trabeculectomies I've done. The diflupregnate just gives you these very nice blebs, especially in our population. I wish it was available readily in our country, but unfortunately, it is not readily available. Many pharmacies don't have it, but I found it very, very useful. So that brings me to the end of a few things that I just wanted to highlight. And again, I want to thank the speakers. You've done an excellent job. I loved the videos that you projected, Professor Chimdia's video and Dr. Sadiq's video. Excellent. Thank you so much. I hand over to Professor Mahdi. Yes.
Thank you so much for those great pearls. Professor Abdul, please. Is he with us? Professor Abdul? Okay, while he's trying to come on, I think there are questions. Which comes up first? Placement of anti-metabolite swaps or raising the flap? Somebody wanted to know. And then the other question is use of IV acetazolamide instead of IV mannitol if available. Somebody is wondering whether that can be used. And
okay, actually, I've never seen IV acetazolamide, so I don't have experience with it. What we have in our hospital is mannitol. That's what we are using.
Okay, thank you very much.
To answer that question, when raising the scleral flap, do we enter clear cornea before applying anti-metabolite? No, you don't even get to the blue zone. No, you just make your flap, before you get to the blue zone, you apply your MMC. And please don't apply your MMC after you have done a paracentesis. Don't go into the eye at all. So it's just that you've raised a little bit of the flap. You are not yet at the blue zone. The flap is looking good. Then you apply your MMC a little bit underneath the sclera and the other one behind or underneath the conjunctiva. So, behind your scleral flap, underneath your conjunctiva, you place some there, you place some underneath your scleral flap as well. Thank you.
Thank you very
much. This question, Professor Adekoya, there's question, Professor Adekoya. Actually, it's actually MMC injection, 0.4 milligram. That's what we give before we give it in the subtenon space, and before we raise the conjunctiva. It's giving about 6 to 7 mm away from the limbus, and then from there you can now spread it.
What dose do you give?
0.4.
That's okay. That's a lot.
And that's what
the conjunctiva. That's a lot underneath the conjunctiva.
That's what we have. Actually, we applied it in the subconjunctival space, subtenon space, And that's what we have been using for quite some time now.
Sorry,
I
Dr.
forgot the last
Sadiq,
time.
do you get to wash it out?
Actually, we don't wash it
How
out.
do
Once
you?
we give, we don't wash it out, ma. We give it far behind, about
And then
7
you
ml
do
of the
your
limbus
surgery.
inject and spread. So you can't even wash it, it's already there. And then
Wow.
when you
I'll
are
be
giving
very
it,
wary.
when you are giving it, however, when you are giving it, the nurse will be pouring saline to wash any of the antimetabolite that escape. Actually, say about this antimetabolite, MMC is endothelial well, 5-FU is epithelial, you know. So, but this is what we have been using actually.
So
Okay,
many of the books,
I want to say
just to say
that
something. Yeah. Go on, Prof. Go on, Prof.
0.4
Okay.
milligram per
This
mil
is speaking.
conjunctival is a huge, it's too much. In Aravint, they give 0.02 if you're going to do
Yes, that's what most books say. The literature says
But
0.02.
actually, what happened is that the 0.4 milligram is in double dilution. Now, when the MMC come in 10 milligram, it comes in 10 milligram or in 5 milligram. When it comes in 10 milligram and you dilute it by 25, so you now get the 0.4. Now, when you take 0.1 mil of 0.4 preparations, you now dilute it with 0.1 mil. So you take 0.1 mil and make it 2 mil with saline, and then you inject. That's what we use.
So it's no longer
So now
0.4.
it's no more. It's not 0.4 anymore.
It's not
It's no more
0.4.
0.4.
It's actually
Now 0.2.
you are actually giving you are giving 0.1 mil. And that 0.1 mil should actually contain 0.04. You can give between 0.04 to 0.05. That is what you give, not 0.4. Absolutely not 0.4.
What I'm saying is that if we take 0.4, take 1 mil of 0.4. So this in 0.1 mil, that's 0.4 milligram. If you add 0.1 mil again, so it became now 0.4 in 0.2 mils. I don't know, something like that. And you give everything.
Well,
it's still not 0.4.
Yeah, what is advised? What I do is that either you use, if you don't want to use the by applying using maybe the wick or the cotton board, you can inject towards the fornix 0.04 in 0.1. That's 0.1 mil, which is equivalent to 0.04 milligram. You can give maybe like 1 hour before surgery. Then you can do the surgery. You can also use that whenever yes, you can also do that when you are doing a needling. If you want to do needling, you can give it an hour before needling and you do your needling. So when you do, after you finish the needling, you're not giving any other thing. You just probably give maybe soft conjunctival steroid and antibiotics, and the patient goes home. But it's actually 0.04 to 0.05. That's what some persons give 0.02. You know, for us in black eyes, for black eyes, I think 0.04.
But you can see, but you see, generally in the literature, the MMC concentration is 0.2 to 0.5, not 0.0 to 0.0.
No, that is for subconjunctival use. The one that you're talking about.
I actually thought about this thing very well. You know,
May I suggest that we continue this group discussion on the group so that we can move forward?
Yeah.
Yes.
Okay.
Okay, so thank you very much. I think there are a lot of literature on this, so maybe later on the group we can continue. So it's Professor Mahdi Abdul around to weigh in on his experience He's not here.
I don't think he's here. I don't think he's here.
Okay. Where do you? Okay, I think this has been dealt with. Where do you put the MMC? Is it subconjunctival under the sclera? That has been dealt with, and the IV acetazolamide also has been responded to. We don't even have it. And then somebody wanted to know, Dr. Sadiq, do you mix the MMC with xylocaine before the subconj injection?
So actually, I was doing that before, but you see, technicality of getting xylocaine, give me that. So it's easier for me to just use saline. So we use saline and not xylocaine. But I know where I trained.
How long do we
I
wait?
don't know. I know where I trained. They use xylocaine, but the book says xylocaine or normal saline. So I go for the normal saline. The advantage of xylocaine is that it helps you in like another anesthesia you are given, and also cause some form of vasoconstriction.
Okay, thank you very much.
Yes,
Says, how long do we wait after the subtenon MMC before
immediately, ma'am. It's immediately. It's immediately. You don't wait for any. Once you give, you continue. That's how I do.
Okay. So
we don't wait for it to.
Okay, you've answered the macula.
If you are giving if you are giving sponge application, then you can put on time and then wash, and then 2 to 3 minutes, you remove it, wash, and then. But when you give, what I like subconj injection is that you don't have to wait that 2 to 3 minutes. It's enough for you to raise your conjunctiva at that time and then do other things. But that's it.
Okay, so thank you very much. There's a question here. What would you advise concerning repeat trabeculectomy? Is there anyone wanting to weigh on it? Dr. Sadiq, Professor Bonaya?
Okay, my repeat trabeculectomy means doing trabeculectomy in adjacent sites. Where revisit if you go to the primary site and repeat the trabeculectomy. Now, I have done like twice repeat trab, and I have not seen the patient for some time now. I didn't pull up that data. But the 2 patients I did, initially the pressure was fine. So I don't know how they are now because we have a very busy, they might have come without me seeing them. But I know according to the book is that after the failure of trabeculectomy, the next to do is glaucoma drainage device. And these devices are now available in our own environment. So I think that would be a good option. But for me, I would prefer to remove the lens before I put the GTT so that AC is dipping, the tube can be far away from the cornea.
Okay, thank you very much. There's another question. Can use of air bubble or visco precipitate or fasten lens opacification? If yes, please, what precautions?
Hi, honestly, I don't know. I really don't know.
Okay, let me just weigh in on that. The question is, air bubble can actually precipitate anterior lens capsule opacification. And so one has to be very careful, especially when you are trying to reform the AC, maybe in shallow anterior chamber or something flat anterior chamber. Air bubble will sort of help deepen it, but it also has that risk of causing anterior lens capsule opacification. It is better to use viscoelastic. Of course, when you are putting in your viscoelastic, you have to be very careful so that you don't injure the crystalline lens. So it's better to use viscoelastic rather than using air bubble. That's what I would say there. I've had that experience once or twice, so I know that air bubble can actually cause some degree of opacification.
Do we remove the visco after the surgery or we leave it there?
No, we don't. No, we leave it there. Now, this is not during the surgery. Don't get me wrong. Now, during the surgery, you can have air bubble. You already have aqueous or BSS within the anterior chamber. So if there's one air bubble or the other, it's not a problem. It is when you have shallow anterior chamber, you're trying to reform the AC and you use air bubble, because you don't have enough aqueous, the air bubble is not going to go up. It's going to sit on the lens, especially if the AC is very shallow. It's just going to sit on that lens and it's going to cause an opacification. So it is better to use, viscoelastic in such situations. Now, if for whatever reason you need to deepen the AC on the table during your surgery and all of that, you can put in your viscoelastic. You don't need to take it out. Usually within a short time, within a few days, it is gone out of the anterior chamber. So, yeah, thank you.
Okay, thank you very much, Prof, for that tip and that information. Then somebody wants to know, how do you deal with thick tenons? Is there any benefit from excising tenons?
Okay. Theoretically, tenons is the source of fibroblasts and therefore could precipitate wound healing and fibrosis and all that. But then removing the tenon will improve the chances of cystic bleed. So I had once seen a study that compared trabeculectomy with tenon removal versus no tenon removal. And they discovered that there is no difference in terms of outcome. But recently I saw one journal in Journal of Glaucoma where they published that leaving tenons reduce the risk of thin cystic bleed. So, however, when you are doing trabeculectomy and sometimes you see the tenons trying to extrude through the wound. So in my own practice, when I see tenons trying to extrude through the wound margin, I tend to pull it and excise it so that I have a proper apposition of the conjunctiva. But like what Professor Lawaye says, this trabeculectomy is one surgery that is done in different ways by different people. And but in my practice, that's what I do. And I remember when I did my fellowship sometime back in Germany, my trainer will make sure that when closing the wound, he particularly catch tenons and now catch conjunctiva and put them together. So from tenons, conjunctiva to close, they always do that.
Okay, thank you very much, Dr. Sadiq. Maybe I can just say one or two things. As much as possible, don't go after tenons at the level of raising your conjunctival flap. If possible, just dissect both the conjunctiva and the tenons capsule together. So you just do the dissection. The tenons capsule is actually about 0.5 millimeters behind the limbus. So that was what Dr. Sadiq was trying to show in his video. Although I still do my phonics-based conjunctival flap, I still raise it from the limbus, but I try as much as possible to dissect both of them the way. Like he said, if you have some tenons maybe disturbing where you are, or it's difficult for you, it's prolapsing through the wound, you can just cut that area off, but don't go after the tenons trying to do a tenonectomy. And the reason is that usually it bleeds. And once it bleeds, you then begin to struggle, with hemorrhage and all of that, making your surgery so difficult, and so it's important that you just let sleeping dogs lie, take it away, do your surgery, complete your surgery. And once you complete your surgery, then you can push back, you can suture down your conjunctiva and tenons. So except the tenons is actually disturbing your surgical site, I don't think you should go ahead to start doing the tenonectomy. It's not really necessary. So that's what I would say regarding removing the tenons. And like you said, the tenons is very important. Sometimes you have a very tiny leak. if you have your tenons, it's going to save the day, you know. So, and then it also avoids you having these cystic thin-walled blebs. So it is so important that, you know, sometimes the tenons is not bad. It can be good, and it can give you that diffuse, you know, blebs. Occasionally, I'm not saying that sometimes it's not just disturbing you and all of that. You can just take away that area that is disturbing, but please don't go ahead to do it in a lecture. Thank you.
Thank you very much, Prof, for weighing in on that. So tenon or subtenon, it's not something we should go looking for, except it gets in the way. We can just take that out and continue with the surgery. I think we've tried to answer all the questions.
There's one more question, Ma. On after subsequent injections of MMC, we don't give it again during surgery. There's a question that asks whether after the subsequent we also still give maybe sponge application during the surgery. So it's only given before you start, but during the surgery it's not given again.
Okay, so that's the last question.
No, there is one other question.
Madam
Something
Moderator,
about what volume of
just a
Visco should be
few
used to.
comments.
Sorry, please. Just
There
trying
are
to
still
make
a few questions.
questions. So
What
Prof,
volume of Visco should be used to reform a shallow AC?
Professor Bola, please.
All right. Thank you so much, Prof, for moderating, and many thanks also to the panelists, and of course a big thank you to the presenters for this excellent presentation. It's very, very captivating. It shows that no matter how long you've been doing trabeculectomy or how short you've been doing trabeculectomy, there is always something to learn. And when Professor Ogunaya was presenting, she listed the key steps when it comes to trabeculectomy. In fact, each one of those steps is enough for a whole full lecture. So you can see that there's no way we can even dissect everything that needs to be discussed for when trabeculectomy is concerned here. So, but we keep learning every day, and I want to thank the leadership of GSN. Can you still hear me?
I can hear now, but it's like you're breaking.
Yes, yes, we can hear you.
Okay.
I can hear you very well.
Yes. So yeah, it just shows that there's always something to learn about trabeculectomy. And thanks to the leadership of GSN for putting this up. Just a few comments. We've made several pearls and pitfalls and various tips for trabeculectomy. And I think a very, very important thing is instrumentation. Good instruments are so critical. A lot of times, a lot of our instruments are not good. You have one scissors that is not cutting. You have an iris faucet that is not picking well. So you've got to invest in your own development. Even if you have to buy your own instruments as a start, it's very, very important. And in terms of subconjunctival, the peritomy, the superior side for the trabeculectomy is good to also avoid the temporal side for future tubes. Some also do subconjunctival injection also for a form of non-traumatic dissection of the subtenon space, and it's also good. And so there are also several ways of applying our sponge for MMC or for 5FU. Some will even pass a suture through those sponges and insert, so that they just pull out the suture. It's like a form of a necklace. So that is also one way of applying our MMC sponges. Thickness of the scleral flap. Sometimes it takes experience, but also it's also important to know. Some have said the bevel of the typical Dera size 15 blade or the crescent knife. So that depth will give us a relatively a good idea of the depth of the superficial scleral flap. The use of AC maintainer is also there. Some have said, oh, use AC maintainer. It will also help us in keeping the anterior chamber well maintained. And ideally, just like the Professor Ogunaya showed in the video, ideally our peripheral iridectomy should be done outside of the AC. Okay, we should wait for the iris to come to us rather than us chasing the anterior chamber, taking the iris into the anterior chamber. Of course, not as if you can't do it if you still need to do it, but ideally, with the wound construction and the anatomy and the physiology, ideally the iris should come to you. And of course, when we are closing our conjunctival suture, we should endeavor to bury the sutures if you are using non-absorbables, because the irritation, that's part of what makes the quality of life of the patient to be not to be don't to deteriorate, because when the patient is having constant irritation from exposed suture, irritating sutures, that may not, even if the pressure is fine and everything, and so that constant irritation is also something that we should avoid. I think that's all. So like I said, we keep learning, and trabeculectomy, you can never not learn in one or two things each time you listen to a lecture on trabeculectomy. Concerning the Pitfalls, what Professor Olawe said is not easily available. It will be good to see what the market looks, because a lot of our poor response and poor inflammatory response, poor healing is due to insufficient anti-inflammatory drugs that we use. So I don't know, I mean, we have fake drugs in other places. I don't know whether we now have fake, it will not be surprising if we have fake steroids all over. So you think your patients are using the steroids, whereas they're not getting that steroid that they actually need. So I quite agree that we have to be very, very particular about the type of eye drop. The brand is, in fact, of the eye drop that the patient will buy. And we have to, it's not about whether you are promoting one drug or not. It's about ensuring that our patients get the required anti-inflammatory agents. Thank you very much. Excellent presentations.
Oh, thank you very much, Prof, for this addition that you have made to the discussion. I want to thank the presenters and the panelists and everyone who has weighed in. I think
just one more, passing comments before we round it up. I know our time is fast spent. I hope you don't mind. There are still a few questions that we didn't answer, except you don't want us to answer those ones.
No, we want to.
What do we? Okay.
Did I miss any?
Yes. So somebody was asking that what volume of visco should be used to reform a shallow anterior chamber. Now, that volume will depend on how shallow your shallow is. The important thing is that you want to form the anterior chamber on the slit lamp. If you're reforming the anterior chamber on the slit lamp, or if you're taking the patient to theater, the important thing is that you don't want the eye to be hard. You don't want to push in so much that the pressure is as high as 50. You want the eye to be firm, and you want it formed. So that is important. So it really depends on how shallow your shallow. If it's flat, you're going to put in more. If it's just moderately shallow, you may just put in a little bit. So it all depends on how shallow your shallow is. Of course, we have the grading for shallow anterior chamber, which I'm sure will be discussed tomorrow. There's somebody here who said something about viscocohesive. I think that is just for information. Thank you so much. Just to also mention that if you are using Maxidex, please let the patient mix it, because it's sort of, the active ingredient has a way of settling down. And so if the patient doesn't mix it before using, you may just be putting in water and the active ingredient is just right underneath the bottle. I just wanted to chip that in before we end the discussion today. Thank you so much, Madam Moderator, for giving me this opportunity.
There's a hand up.
There's a hand up, please. Before that hand up speaks, there's a question on wipeouts. On wipeouts, it says, let me see if I can get that question. I just realized we passed it. When do we say wipeout has occurred with respect to visual acuity?
Okay, I can share one experience. I think I've seen one wipeout. This was a patient who was having a repeat trabeculectomy, had very bad fields, had a 6/9 vision, but very bad fields. I mean, that field was so bad. But we did the surgery was done, and I remember that that particular day I wasn't in the theater, so I wouldn't know what happened in the theater. But the following day when we saw the patient, the visual acuity was hand movement. Now, if the best corrected visual acuity pre-operatively was 6.9, and then post-operatively, first day post-op, hand movement and the intraocular pressure was 34. In fact, I can't forget that number. It was 34 that day. And we thought, okay, maybe it's macular edema, maybe it's this, maybe it's that, but the patient never regained the vision. So, wipeout syndrome, at least that was one case of wipeout that I saw, came from 6.9 to hand movements. And the patient for years after that remained hand movements. So that's an experience. Thank you.
I think I would like to say something here. The person is asking in terms of how do you quantify what level of vision will you qualified as what level of visual loss or drop in vision that can qualify as wipeouts. So I once saw in the literature is that when there are 2-line drop unexplained, that cannot be explained by any complications, by anything. One thing about wipeout is that wipeout is a diagnosis of exclusion. You have to exclude all other causes of poor vision. Patient has not had macular edema. Patient has not had a lot of astigmatism. Everything was fine, no complication, nothing, good trabeculectomy, but there is loss of central vision, and that is the wipeout. So remember.
No, go on.
Yes, ma'am. So I could remember I saw a publication like that. When you have two or more line drop in vision, that could be termed as wipeout. But another one that I read recently is when there is loss of central vision. So they did not quantify, but they say loss of central vision in a patient with advanced glaucoma. So this is a good question. He wants to know at what level. Maybe somebody is 6'6", now become counting finger. Is it a wipeout? Or somebody is 6'6", has become 6'18". Is it a wipeout? So this is the question that the person is asking.
I just wanted to say that no, most literature will say loss of central vision, and loss, not 2 lines, not 3, loss, like hand movements, LP, CF, maybe if it was 6'6" before and it comes down to that kind of thing, it's loss of central vision. And it's irreversible and it's unexplainable. And, we have a lot of less than 2 or 1. In fact, it is said that in most cases, right after your surgery, the visual acuity of your patients could actually reduce by 1 or 2 Snellen's line. Of course, we know all the reasons for that, but that would be termed as wipeout. I think it's that loss of central vision that is termed and defined as wipeout.
Okay, there's a hand up, please. Quickly, mute and speak. Professor Chu.
Yes. Thank you much for all the presentations and the comments. Thank you to the panelists.
Prof, you are breaking. I hope you are breaking, Prof.
You are breaking. We are not here.
Oh, Prof, oh gosh, we would have wanted to listen to Prof.
Session. Okay, I want to relocate. Probably I'm looking for the top of the 3. Hello, is it better? Hello, is it better?
Yes, it's better. It's better.
Okay, I think I'm almost on top of the 3. Okay, so so the question is, Professor Laurier did mention that if you want to use Maxitex, advise the patient to mix it. Please, I want to understand what you really mean by mix. Mix with what? Hello, did you
sorry
get
about
me?
that. Okay, so yes, I did get you.
I think
So
shake
can you hear
the
me?
bottle.
Shake the bottle. That's what I mean. Shake.
Okay,
No, not
shake,
mix
not
with anything. Shake. Yes, shake the bottle.
Okay.
That's the appropriate word.
Okay. Thank you. I wanted to know whether there was something to mix it. Thank you. Thank you very much.
Thank you.
Okay, thank you very much. So we'll check. Always remember to tell our patients to shake the bottle. And okay, I think at this point I'll just hand over to the chairman, Professor Wilson. I hope.
Wow. Yes, I'm here.
What has happened?
So much. There's so much that we have heard.
Thank you so
Go back to you, Ma.
much. Yeah, we still try to keep to time because we're supposed to be ending by 6 and it's 1 minute to 6. So thank you so much. Thank you to all our presenters. Excellent job. And all our senior colleagues. I saw Professor Adiola Onokaya. She didn't say anything, but I saw her on the call. And Professor Akinshola, I also saw you. Professor Morgan is also around, Professor Chikakusa. And I probably have missed 1 or 2 people. We are so grateful. We're so grateful that you could take time to come and be with us this evening, shed more light. You can see that this trabeculectomy is not something we can never stop talking about. It's the gold standard. It will continue to remain the gold standard for a very long time. And I hope all the residents have also been here because in the exams, when they are asked this question, it shouldn't be unfair. We have dealt so much with this topic, so they should be ready to move so much stuff. Thank you so much. So for tomorrow, it's going to be the last day. This is what they call the bottom pot, the last day of our Zoom lectures. And the topic is going to be on the post-op complications and how to manage your bleb after your surgery. So there's a whole lot going to happen tomorrow again, and we really would like it if everybody would be here again with us tomorrow as we continue on this program. If I've forgotten any person, please just forgive me. It's not intentional. And our GSN chairperson, Professor Lawe, thank you for being with us, for shedding so much light, bringing your experience to bear. So thank you so much, everyone, and we hope to see you again tomorrow. Okay? Professor Ibanga, thank you for moderating for us today. You did a great job. Okay. All right. Thank you, everyone.
Thank you, everyone. Thank you, our chair of the GSN.
Thank you so much. Good
We
night.
appreciate you. Thank you. Bye-bye.
Bye.
Thank you, everyone. Bye.
Bye. Good night.
Bye.
Bye.